Hello, I'm Jonathan Kay, reporting from ACR Convergence 2021, which was supposed to be in San Francisco, but we watched it from home. I'm here with Kevin Winthrop, who's a professor of infectious diseases and the guru on infections and rheumatology in our drugs. So, Kevin, the oral surveillance study presented data about infections at the ACR meeting. What are your thoughts about that?
Yeah, it was nice to see the update because, prior to this, it really just been the interim data cut that had been in the public domain. And, what did we learn? I think it's pretty consistent with what we've seen before in terms of the herpes zoster signal being there, threefold higher risk for TOFA users as compared to TNF users. But, if you look at the serious infection data in general and as well in those that are elderly, it's also similar to what we've seen in trials. I've always thought that the risk of serious infection in general is largely the same between TNF blockers and JAK inhibitors. At least that's what we would garner from the clinical trial experiences of those drugs coming through, as well as the real world data that's out there. If you look at oral surveillance, you look at that high risk group, the people who have higher rates of serious infection, age 65 and above. You really didn't see a difference between the approved dose TOFA 5 BID versus the TNF blocker. It was about the same. When you looked at younger people, there was some suggestion that the risk was slightly higher with TOFA, but it wasn't statistically significant. TOFA 10 is a different story. You see much higher risk levels for infection, both shingles and general serious infections with TOFA 10. And you see that as compared to TOFA 5 as well as versus TNF blockers. So that's something we've also known from prior experiences. So the oral surveillance data, we won't talk about VTEs and all the other things today. We don't have time. But from an infection standpoint, I think it looks pretty similar to what we've seen before with TOFA, as well as the other JAK inhibitors.
So from the standpoint of infections, nothing really new. It's important to remember that the oral surveillance study was limited to individuals 50 years and older who had at least one cardiovascular risk factor. So it doesn't apply to the entire general population.
I think if anything, and I haven't seen the data modeled and we haven't looked at risk factors in that data yet, but from the crude incidence rates that reported, it's somewhat reassuring that in older individuals, if you're going to start them on TOFA 5 or start them on adalimumab, you can expect about the same risk of infection. So I think if anything, it's somewhat reassuring, in terms of using JAKs in older people from an infection standpoint.
Well, that's good to know. Well, Kevin, it's always a pleasure to get your insight on infections and lots of other topics as well. I would direct people to our other interview on rheumnow.com and other videos about ACR Convergence 2021. Thanks for listening. I'm Jonathan Kay with Kevin Winthrop.
Thanks, guys. See you later. Cheers.
Thanks.